Welcome everybody to this MDS roundtable. My name is Guillermo Garcia-Manero from the Department of Leukemia at the University of Texas MD Anderson Cancer Center, and I'm very pleased to be here today in this teleconference with some of my colleagues that are also experts on this disease, and we're going to be spending hopefully a very informative next 32 minutes to 1 hour discussing topics around myelodysplastic syndrome and some of the data that we saw at EHA.
I'm Dr. Jamie Koprivnikar. I'm joining you from the John Thur Cancer Center at Hackensack University Medical Center in Hackensack, New Jersey. I'm a member of the Division of Leukemia here. Great to be here today.
I'm Chedid. I'm a hematologist, medical oncologist, obviously. I'm a community oncologist. I've been in practice for about 20 years. I was in academics previously with the University of Texas Medical Branch in Galveston, but at present I'm a community oncologist in Singing River Cancer Center down at the Gulf Coast, Mississippi.
Hi, everybody. Tom LeBlanc from the Duke Cancer Institute. I'm part of the Leukemia and Myeloid Disease Group and serve as the Patient Experience and Safety Officer for our cancer center.
Let's start a little bit. I'm going to ask Jamie perhaps to give us an overview of what you think is happening in low-risk MDS over the last couple of years that I think is quite exciting and interesting.
I could not agree with you more. So we are all of a sudden having a lot of treatment options for our patients with lower risk MDS. And this is a field for a long time that was largely ignored. For our transfusion-dependent patients with lower risk MDS, we really did not have a lot of great options. Sort of the de facto standard of care maybe, 3-4 years ago was therapy with erythropoiesis stimulating agents, transfusion support. And, if that failed, we would consider disease-modifying therapies like, for example, hypomethylating agents. Of course, this is the notable exception to this was patients who had del(5q) MDS who've shown to benefit in terms of anemia by, more targeted therapy with lenalidomide. So more recently, there have been some major developments. A few years ago, we saw that luspatercept was approved in a specific subgroup of patients with lower risk MDS, those patients who had disease associated with ring sideroblasts who were transfusion dependent. And this was in the second line setting for patients who had tried and failed an erythropoiesis stimulating agent or who were deemed ineligible for an ESA based on an elevated erythropoietin level. And so then more recently, seeing how well luspatercept performed in this particular group of individuals, this was shown as part of the Medalist trial, there was a much broader trial of luspatercept undertaken in the frontline setting for all comers with lower risk forms of MDS. So again, patients could have very low or intermediate non-deletion 5q risk MDS. They had to be ESA naive and have an EPO level of less than 500. And as part of this trial, the COMMANDS trial, patients with lower risk MDS were randomized to receive either luspatercept or weekly epoetin alpha. And so what we saw with this trial with COMMANDS is that patients in terms of response rates with transfusion independence, we saw actually an improved response rate with luspatercept as compared to erythropoiesis stimulating agents. And I know we'll spend time talking about the COMMANDS trial in further detail later on, but certainly this COMMANDS trial really established a new potential frontline standard of care for patients with lower risk MDS who may require transfusions. And then more recently, we've actually had another exciting approval, and this is the approval of imetelstat, which is a telomerase inhibitor. And really, this group of patients is quite distinct from that who were included in the COMMANDS study for the most part. So these were patients, whereas COMMANDS enrolled patients who were ESA naive, the trial, the IMerge3 trial that ultimately led to the approval of imetelstat, enrolled patients who were either ineligible for or refractory to ESAs. And we saw, about a 40% response rate in terms of a period of transfusion independence, also in this transfusion-dependent patient population. So we've had, really some practice-changing developments over the field of lower-risk transfusion MDS and in patients with MDS who have symptomatic anemia over these past several years. So it's a really exciting time, certainly, to be treating these patients. And I'm glad that our patients have, more options.
Wonderful. So I think if we're gonna put all this together, focusing about the low risk MDS, we've gone from ESAs only to basically now luspatercept in frontline patients, in my opinion, although we could argue and maybe discuss this a little bit later. For sure, this drug is extremely active in rinsoblastic positive disease, but the data that actually was just also published in Lancet Hematology a week or so ago indicates that also in the RS negative group of patients, this drug is highly effective. So we have that in frontline disease, and now we have imetelstat, as you mentioned, in second-line disease. We should note also that the IMerge study, majority of the patients were actually were also predominantly RS positive, which is actually kind of interesting, right? So that's really important major development. Of course, we still have the ESAs for those patients that will benefit from these erythroid-stimulating agents, lenalidomide for the patients with del(5q) disease. And there was actually a very recent study from Europe, just published also in Lancet Hematology, with the early use of low-dose lenalidomide, 5 milligrams in transfusion-dependent patients with del(5q) disease. So that's quite important. And of course, the hypomethylating agents that had been part of what we do for many, many years. Of course, younger patients may be candidates for transplantation. We have those patients with hypoplastic myelodysplastic syndrome that we tend to treat like aplastic anemia. So all of a sudden, actually, as Jamie was saying, the armamentarium is really, I think, complete. Now we need better drugs for low platelets and things like that. But I would like to ask our experts, as we have this opportunity here, for their perspective. So the first one is actually for Soli. That is, what is your perspective as a more community, and I say that with all my respects, but a more community physician dealing with these new drug developments for our patients with MDS? Because my perception is that probably the majority of the patients with this disease don't go to Hackensack or Duke or MD Anderson. They probably go to see, their local center. So what is your perspective on this kind of development, and how do you think they have been or are being incorporated in your practice?
Well, I mean, aside from initially making the diagnosis and making sure that other confounding factors aren't being addressed, knowing when to refer patients to centers of excellence is really important. And I think that's where the IPSS-M sort of excels, because in the IPSS-R, I think we were missing some patients that were high risk. And I think those were being captured a little bit with a little bit better fidelity with the IPSS-M. So some patients that initially looked like they were going to do relatively well and weren't doing well, those patients, I think we should refer much earlier to transplant or for being treated as a high-risk MDS rather than simply a low-risk MDS. That being said, most of our patients are presenting with anemia. So they're presenting feeling bad, and especially in my practice, many of these patients already have COPD, congestive heart failure, that sort of thing. So even a hemoglobin below 10 is they're very symptomatic with that, and raising their hemoglobin by 1, 1.5, 2 is a big deal when we can keep that elevated, especially with agents like luspatercept, which can keep their hemoglobin raised for a really protracted period of time. So, I mean, from my perspective, it's all about quality of life and keeping patients out of trouble for a longer period of time. Now, sequencing is certainly going to be a challenge, and I think I would love to get y'all's input on that as well, in terms of which products. Insurance companies would certainly like us to use the least expensive product up front, but at the same time, the patients are having to come in every single week, 52 visits a year compared to potentially only 17 visits a year for luspatercept. So that, the opposite side is also very, from a quality of life perspective, being able to raise the hemoglobin a little faster with luspatercept, being able to raise the hemoglobin a little longer with luspatercept, and having far fewer visits. From a quality of life perspective, that's essentially what it's all about, is helping patients, have the best quality of life they can.